Hello, everyone. Welcome to this medical podcast. I am Dr. Harshita, your host, and we are honored to have with us our esteemed guest, Dr. Renuka Gupta, a renowned gynae oncologist. Dr. Renuka brings a wealth of expertise and a compassionate approach to her field. Doctor has honed her skills at esteemed institutions such as Tata Memorial Hospital in Mumbai and Kidwai Memorial Institute of Oncology in Bangalore. Currently, Doctor is working as a senior consultant in gynae oncology at Sri Agrishen International Hospital, Delhi. With a rich experience spanning over 16 years, Doctor possesses a deep understanding of her field, specializing in colposcopy, the management of pre-cancer lesion of cervix, LEEP, cryotherapy, and hysteroscopy. Dr. Renuka has published multiple papers and chapters in various national and international journals and books. In 2022, Dr. was honored with the prestigious Women Healthcare Leadership Award in Oncology. Dr. Renuka emphasizes delivering the best possible care for her patients and has successfully treated a wide range of female cancer cases, ensuring complete recovery. We extend our sincere thanks for being with us, Dr. Renuka.
Thank you, MedSynapse community for calling me for this interview. I think I will enlighten some issues and it will be a great pleasure for me to have this on your stage. Thank you.
To discuss the crucial topic cervical cancer. Doctor, what factors do you believe have contributed to significant increase in the incidence of cervical cancer, leading to a tripling of cases?
So, first of all, we all know that cervical cancer is fourth most common cancer worldwide in women, and it is second most common cancer in India in women. So, because of this effective screening, I overall can say that incidence in the developed world is decreasing nowadays because of effective vaccination and screening schedules. But in India, as we have only the opportunistic screening and even opportunistic vaccination, because we don't have any vaccination schedules for the young girls and we don't have proper screening programs, that's why we cannot detect these cancer on time. So that's why incidence in India is not decreasing as much as decreasing in the developed world. But still, incidence is not increasing for the cervical cancer. Incidence is now decreasing. So trend towards initially cervical cancer is the most common cancer in India. But now cervical cancer is second most common after the breast cancer. So incidence is decreasing, not increasing nowadays. And factors which are responsible for the cervical cancer are basically the young girls having a sexual contact at very early age. It is previously said that patients get married at very early age, and then early childbirth. These are the usually contributing factors towards the cervical cancer. Main important is sexually transmitted infections with HPV. So HPV is the main positive factor for the cervical cancer. So now we have developed the HPV vaccine, HPV testing, and number of the procedures like colposcopies and using a lead to treat the precancerous lesion. So we can decrease the incidence rather than increasing. So nowadays these are not increasing; trends are decreasing towards the.
Okay, Doctor. Thank you for sharing your insights on this. And my other question would be, what are the factors that determine the stage and severity of cervical cancer, and how these factors influence the prognosis and treatment approach?
Okay, if we see the stage, we know that each and every cancer is having a four stages of disease. We'll usually denote the four stages, and all the prognosis usually in a case of cervical cancer, prognosis usually depends on the stage of the cancer. So in stage one, this is only basically limited to the cervix, and in a stage two, it goes goes out from the cervix, and in stage three, it goes towards the pelvic wall, and in stage three, it's a metastatic cancer. So even in a stage one, the cancer is having a different parts, that 1A1, 1A2, 1B. So we are categorized these stages into subcategories to define our treatment guidelines. So definitely stage is playing a significant role in prognosis, because when we diagnose the cancer in an early stage, it is completely treatable. It can be treated with a surgery alone, because if it is diagnosed in stage 1, even in the 1B2, we can treat the patient with the surgery. But if disease advanced to the stage 2B or bulky stage 1B, then we have to incorporate the radiation and chemotherapy in our treatment. So definitely stage plays an important role in a prognosis. And in case of CA cervix, prognosis usually depends on the stage only, because in stage 4, disease is metastatic. It's usually in 4 it goes to the bladder or bowel, and in stage 4B it's metastasized to the lungs and liver. So if we are dealing with the patient of stage 4, then we have to treat with the chemotherapy only. So definitely treatment is tailored according to the stage, and prognosis definitely depends on the stage.
Okay, doctor, thank you for your comprehensive explanation on the factors and impact on prognosis and treatment approaches. And the another question is, like, what consideration do you take into account when tailoring treatment plans for cervical cancer patients, specifically regarding age and good health and general health? Sorry.
Definitely, because whenever we are planning a treatment for the patient, it should be in a multidisciplinary approach, because we cannot offer a single treatment to the patient. Whenever we offer the treatment to the patient, we have to keep certain points in the mind, because what is the stage? If she is in early stage or in advanced stage. If she is in early stage, then we have to consider the patient's age, especially the age, because nowadays trend is towards to delayed the childbearing. So if patient wants childbearing, so then we have to tailor her treatment according to her need. And if the stage, after the keeping the mind in mind the stage and the age, that patient is of early age group, patient needs the fertility preservation or not, then patient general condition, because if patient is come in an advanced stage and patient's creatinine is high, patient heart condition is not, and this patient is not fit for the surgery, then we have to refer the patient for the radiation treatment. Patient is fit for the chemotherapy or not, what stage patient has come to us. If patient is came in a stage where we can treat the patient effectively, either with the surgery or with the radiation therapy, so we'll try to treat the patient as for the curative intent. But sometimes patient came to us in a condition where the treatment is not possible. Like patient is came with us with a, in a case renal failure, where we cannot do any treatment for that. Then palliative settings we have to do. So definitely, whenever we plan the patient, we have to keep the stage in the mind, general condition of the patient, and age of the patient into the consideration, so that we can give the better and effective outcome to the patient in a curative way.
Yes, doctor. Indeed, I'm sure it will be insightful for all the viewers to learn these points you mentioned for treating these patients. And my another question is, if a patient with cervical cancer expresses a desire to have children in the future, like what fertility preventions, fertility preservations options are available? How do you incorporate those into the treatment approach?
Very good question. This I have already mentioned in my previous answer, that we have to keep the patient's desire always in our mind.
Yes.
Whenever we are treating the patient, because nowadays age of the patient towards the childbearing is increasing. So whenever we'll diagnose a patient with effective screening, it is possible to diagnose a patient in an early stage. So when we diagnose a patient in a stage 1A, as I already mentioned, that surgical treatment is possible in stage 1A only, in stage 2A only, stage 1A and 2A only. We cannot offer the patient surgery after the disease is extended towards the pelvic wall. So in these kind of patient, it all depends on the stage of the patient for the subcategorize the sub-staging of the patient. If patient is having a stage 1A disease or 1B disease, which is less bulky, that is less than 2 centimeter of size, we have some categorization for the fertility preservation, because we don't want the patient's condition to be get worsened. So we can offer only in these patients where we can do the cone biopsy. Cone biopsy is a procedure where we can remove the part of the ectocervix and up to the internal cervical os. We have to be below the internal cervical os to remove the whole exocervix and endocervical canal. In these cases, if our margins are negative and there is no LVSI, we can keep the patient under observation and follow-up, and patient can retain their fertility and there is no issues in childbearing. In a patient where LVSI is positive or the growth is bulky, so we can offer them the trachelectomy option, that is radical trachelectomy, in which we remove the cervix and attach the uterus with the vagina, and we can do the laparoscopic pelvic lymphadenectomy. So in these type, we have to the complete staging. We remove all the disease part and we preserve the fertility of also. But in these cases, we have a particular strict criteria which has to be followed before the surgery, so that we are dealing with the limited disease, because we don't want any recurrence near future. So there are certain criteria that there should be not a metastatic disease. It should be stage 1A or 1B, B2 only, with less than 2 centimeter of the growth, with no metastatic disease, with no LVSI, or if LVSI is positive, we definitely do the lymph node staging. If lymph nodes are positive, then definitely we have to refer the patient for the CTRT. So if we'll refer the patient for the CTRT, there is no role of fertility preservation in these cases, because disease get advanced. So we have to keep a number of points in our mind, but definitely fertility preservation options are available for the young people.
Yes, doctor. Very accurately explained this, and I'm sure the viewers will take a note of everything that you told, all the important points on fertility preservation options. And then moving on to the next question, could you discuss any recent advancements or new treatment methods in cervical cancer treatment that have shown promise in improving patient outcomes and reducing side effects?
Definitely, there are number of advances are there in a cervical cancer treatment. We all know that previously cervical cancer, we are not offering any advanced treatment for the cervical cancer, for the cancer itself, because cancer ka naam means patient to jiyega nahi. But nowadays we having a number of treatment. So initially when cervical cancer treatment is diagnosed, it was usually offering the cobalt therapy of radiation, which is through and through we are giving the therapy, and it was giving a number of side effects even up to 20 years after the radiation therapy. But nowadays we are having a proper IGRT, IMRT, in which we are usually planning is based on the imaging, and proper imaging is done to reduce the side effects towards the bladder and bowel. So patient is having very minimal side effects with the ICRT also and with the EBRT also, basically external beam radiation and internal cavity radiation. And these are planned with the help of proper imaging. So dose is only towards the tumor, not towards the bowel and bladder. So we can reduce the side effects of bowel and bladder. These are very good advancement in radiation therapies. So now we don't having any tension to send towards the radiation to these kind of patients. And another term in initially, whenever we are doing the radical surgeries for the CS cervix, it was in a radical hysterectomy type 3, in which we are keeping the catheter for the 14 days, and usually patient is having a bladder atony or bowel atony. So usually they are having a serious bladder and bowel problems. But nowadays advancement number of instruments are there, that we are doing a nerve sparing radical hysterectomy. So type which has been changed, which reduces these kind of side effects, and patient usually gain their bowel and bladder habits on time. So patient usually don't have any symptoms of bladder autonomy or bowel habits is not getting changed. And further advancement in the chemotherapy. Initially, when there is a persistent or metastatic disease is there, we are usually giving the patient the palliative chemotherapy. Now, there is anti-angiogenic factors are included in the chemotherapy like bevacizumab, which increases the lifespan of the patient. Even nowadays, immunotherapy is incorporated into the treatment, so which further increases the responses towards the chemotherapy and palliative treatment is there, in which patient is getting the better cure and better overall survival.
Yes, doctor. Doctor, as you mentioned about immunotherapy, can you bit elaborate on the use of this immunotherapy as a therapeutic approach to manage such patients?
So, if I'll explain the immunotherapy, that immunotherapy is basically, we all know that immunity is our body cells which fight against the germs. So we know that our immunity also can fight with the tumor cells also. So if we'll see that what is immunotherapy? So basically immunotherapy is our body cells which are enhanced immunity, either in the form of vaccination or adoptive T cell therapy, or in the form of immune check inhibitors. So nowadays there are various trials are going on towards the immunotherapy, having a promising results in a phase 1 and phase 2 trials. But phase 3 trials is only the FDA approval drug is pembrolizumab. This pembrolizumab is a PD-L1 inhibitor, that is immune checkpoint inhibitor. It basically having a checkpoint, inhibit the checkpoint. So it is having a very wonderful drug, and it is used in the chemo along with the chemotherapy, that is with the paclitaxel and bevacizumab, and it increases the lifespan and overall survival by 8 months. So it is very promising drug now. And therapeutic vaccines are under trial. They have used the vaccine with the chemotherapy, but still it is not approved for the treatment, and other therapies are also under trial. So immunotherapy is definitely having a promising role in future.
Okay, doctor, it's really interesting to know this. And moving on to another question, what is your perspective on the role of HPV vaccines in preventing the cervical cancer, and how do you educate your patients about the importance of vaccination and while addressing their concern?
So, first of all, if we want to know about the HPV vaccine, we should know why the vaccine is important in this, because it is the only vaccine which is against the cancer. So that is why this vaccine is effective basically. So first we have to know that HPV is a virus which is a sexually transmitted infection, and this virus, if persists into the cervical canal or into the cervical epithelium or vaginal epithelium, the persistence of HPV causes some changes, because it is an oncogenic virus. It is having a E6, E7 protein which changes in the host cells and produces the carcinoma. So persistence of HPV infection is necessary for the development of the cervical cancer or vaginal cancer or vulval cancer. So we have find out the certain vaccines against this HPV viruses, because we know that the positive factor of HPV, 80% of the cervical cancer is caused by the HPV. So definitely we have developed by this capsid proteins, immunogenicity against this capsid protein which prevent this infection. So if we'll vaccinate our girl child at the time before the sexual activity, definitely it reduces the chances of infection with the HPV. So definitely if infection is not there, then the persistence of infection is not there. So 80% chances to reduce these virus infections. So definitely We can reduce the cervical cancer, vaginal cancer, any cancer which is caused by the HPV. Not only in the females, even in the males, this virus can cause the anal cancer in homosexuals, penile cancer, and oral cavity cancers also. So we can prevent six type of cancers in both in males and females. So these vaccines are available at the for the boys and girls, both boys and girls. And the age group usually recommended for this is 9 to 14. It's the ideal age in which only two doses are sufficient at 0 and 6 interval. If patient is more than 14, we can give it up to the 26 years of age. It is recommendations that catch-up dose can be given up to the 26 years of age. Even if patient has not received this up to the 26, in India we have recommended ages up to 45. So we can give these vaccination to 9 to 45 years of age and prevent these HPV infections. So with the HPV, and I hope if all the patient get vaccinated in near future, we can eradicate the cervical cancer also.
Yeah. So my last question is, any special patient case you would like to share with our viewers?
Yeah, sure. I would like to share my recent two cases, just to show that what is happening if we diagnose the patient in advanced stage and what will happen if we diagnose the patient in a very early stage. So one patient of 33 years old came to me. She's just having a symptoms of foul-smelling vaginal discharge and nothing more than that. So we have taken a pap smear of her, but pap smear is negative. It is reactive inflammation only because she is having a vaginal infection repeatedly. So we did colposcopy for that patient and we found some abnormality and took the biopsy. And in biopsy, it shows a microinvasive cancer, that is stage 1A1. So in this, we did just bone biopsy for the patient, that is and in which we have a negative margin, LVSI is negative. So that bone biopsy gets suffice for it. She is having a proper sexual life, she is having a proper life, and she is now out of danger of the cancer. Though she has to be in observation for the next 20 years definitely, because HPV usually retain into the vaginal wall, not only in the cervix. But at least we can prevent the progression of the cervix towards the advanced stage. So she is happy now. And now, but another case, I just want to show that one patient came in a casualty in shock. When we investigate her, she is in renal failure. Her creat was 10. On an investigation, we found that she is having a hydronephrosis. One kidney is not functioning. One kidney is having a severe hydronephrosis. Her creatinine goes up to 10 because of obstructive uropathy. And what we have done, we'll just see a CT scan done that shows on examination. First of all, she didn't give any history of any type of bleeding after menopause or any type of discharge. Maybe these are because of social taboo, because patients are not aware for what they have to bring the notice that what they have to see the doctors, because maybe she is widow, so she's ashamed of any problem discussing with her children and all. I don't know, but when we examine her, she is having a frank growth on cervix, which is having communicated with her bladder. Her bladder is full of clots, and she is not able to pass the urine at that time. So she is having a very large fistula at present. So we did biopsy for her, we did cystoscopy, DJ stenting for her, but her creat is still in 6 and 7. So once that creat gets normal, then only we can start treatment for her. And even whatever treatment we can plan, it's only palliative setting, not the curative setting. Because patient's general condition is not fit for any kind of treatment now. So these are the two case scenarios, that a cancer which can be diagnosed at a very early age with a effective screening method, just a pap smear HPV test, which is very effective, and it is a very easy OPD procedure. So we can prevent these cancer in a very early stage, very early age. Even we'll find out the cancer in the pre-cancerous stage. So it will not increase towards the cancer. Another, if we'll ignore it, we'll find it usually in advanced stage. So 90% of the ladies came in advanced stage only, where the treatment is CTRT. Very few cases came in an early stage where it can be treated with the surgery only. So it's very important to spread the awareness towards the cervical cancer, that it can be preventable, it can be eradicable with the effective screening and vaccination.
Yes, doctor, the experience you just shared holds immense value for us, and I am sure our viewers are inspired and educated while learning about this case. Wonderful, and we'll end the session today. So thank you, Dr. Renuka. We extend our sincere gratitude for your time and the valuable insights you shared regarding cervical cancer. And with that, we come to the end of today's episode. We hope you find this discussion informative and insightful. Remember to stay connected with MedSynapse for latest advancements and expert knowledge. We look forward to bringing you more enriching and discussions in the platform. Thank you. Bye-bye.
Thank you.